Good morning, everyone, and a warm welcome to all of you today joining us face-to-face at the Section 7 offices, as well as the people who are joining us online. Just want to welcome you to the Stop Stockouts launch of the report. My name is Candice Sahoma, and I'm the Access Campaign Advocacy Advisor working for Doctors Without Borders. As we wrap up Women's Month, the Stop Stockouts Project draws attention to the ongoing problem that women face in accessing contraceptives and ongoing stockouts on contraceptives, which, as you might know, affects many who identify as women, and myself included. And as you can imagine, strips people of their dignity, strips people of their agency, and just their overall control over their sexual and reproductive health. As the month of August, as you all know, marks a very important time to celebrate women's achievements, to celebrate women for being women, and the important strides made over the years to see women participating in our society as well as in our economy, and to also have some level of autonomy to make decisions that affect their lives. In the same spirit, as we celebrate women's achievements in a world that chooses to perpetually discriminate against women and deprioritize women's issues. I think it is very important for us to not tire and to continually work against existing barriers that prevent women from fully realizing their full potential. So the Stop Stockouts Project has identified a lack of access to contraception as one of the glaring issues that negatively impact women in South Africa, and especially women and girls in rural areas. Difficulties accessing contraceptives violates or limits women's sexual and reproductive health rights, including their rights to life, to health, to privacy, to education, to equality, freedom and security, and of the person's dignity. So the Stop Stockouts Project conducted a survey to collect data on contraceptive availability across the country. The data was collected by Reproductive, a community-led monitoring project between April and June 2022. Today, I'm really excited. So as we launch the Stop Stockouts report entitled Access to Contraceptives in South African Public Health Clinics between April and June 2022, I'm joined by a panel of very powerful women who are experts in their own right, who have hugely contributed to the making of this report, as well as contribute in their line of work in advancing the lives and access to healthcare for people who identify as women. So starting us off, so we actually have some people, we have Sihle and Ubaone joining us face-to-face, and we have Lucy as well as Indira joining us online. So starting us off today, is it fine? Starting us off today, Indira Govender is a public health medicine specialist and a member of the Rural Doctors Association of South Africa. She has been part of the Stop Stockouts Steering Committee since its foundation in 2013. She will be taking us through a very important presentation on the findings of the report, how they went about gathering the information, and the recommendations that came out of this report. Indira, please do take the floor.
Thanks very much, Candice. I hope you can all hear me well. I'm going to dive right in. There's my presentation. Try this again. It worked a few minutes ago, and now it's not appearing.
No worries, we still have a bit of time, so just relax.
Okay.
Also, just to remind people, as Indira is busy trying to fix her presentation, please do put your phones on silent. And also, I forgot to mention, so the bathroom, if you need the bathroom, just go out the door, turn to your right, and as you go out, there should be some bathroom for anyone who needs it. Thank you.
Okay, got it. You should be able to see this. So, can everyone see this? The screen is. Are you able to see the presentation?
Yes, it should be.
Okay, thanks. So, thanks to Sasha Stevenson who put this presentation together for me yesterday. Walk you through the results. You can find all this information on the site. It's publicly accessible. It just requires a bit of explanation of this. So you heard from Canvas, it's a community-led clinic monitoring. And we were really fortunate to be able to get Richizia additional questions to their existing data collection tools. And so in the last quarter, to June, they surveyed over 15,000 patients, so 15,750 to be exact, to health facilities across 7 provinces. So excluding the Western Cape and the Northern Cape. This is just showing you the demographics, so you can see that the majority of surveyed were over 25 years old, 2/3 of them female, like 63% identifying as people living with HIV. So the first question asked in terms of the stockouts was whether any of these patients, so 14,815 patients received, and it was about whether in the past 3 months any of them had left the facility without the medication that they came for due to a shortage. So it was asking them, did you, anyone you know, leave the facility without the medicine due to a shortage? And so, it's great. 5% said no, and then 10.7% said they don't know, and 6.9% said yes. Now, there's always the option no or trying to respond for all of the questions so that nobody is, forced to say yes or not responding if they don't want to. So in terms of that 6.9, it's about 1,018 of the 14,800. So then the next question was about what type of medication that they didn't get. So the people that said left with, they didn't get what they needed, we asked them what type of medication was it, and you'll see that 40% of that of these patients contraceptives. Like quite an obvious statement that contraception is a problem at the moment, accessing contraception in. And if you look back at the previous reports that we've done, so we never asked about contraception previously. We've usually focused on TB and some primary healthcare medication and vaccines. And this kind of 16% of it's always been like that since we started doing. The first time we started asking about 40% as a response saying that contraception was out of stock. Looking at asking whether the stockout or shortage occurred on the day. And again, you can see that 41.5% yes, 31.8% said no, and then about 27% said that they did. Um, just to recap, these patients were surveyed over a 3-month period. This question asked them to recall in the 3 months whether they'd left without medicine, and asks about the day that they're being interviewed, whether they were experiencing a stock. This question then comes from the facility staff survey. So here we ask whether or not they, what is their response to a stockout or a shortage. I'm just going to open my. So the question here, so we see that about 67.6% said no. We gave them an alternative. 17.7% we gave them a short supply, and then 11.7% said yes. Now, again, is from 367 health facilities across 7 provinces, and most of those are actually, problematic, but we can on facility responses to the type of medicine shortages. Again, so we've got other medicine and diagnostic tests, which includes a range of different types of medicine categories. Contraceptive still comes out as more than HIV medicine or vaccine. The type of contraceptive shortage, again, this is from health facility staff. By far, it is the injection, so the depot hormonal contraception, usually for 2 or 3 months. That is by far type of contraception that is out of stock. And then we asked what are the alternative options for contraception stockouts. So most facilities are recommending that patients who don't get they want are switched to a different contraception. 5% 5% refer to another facility, and 5% back when the commodity is back in stock. We also asked to facilities from the Department of Health on how to manage contraceptive stockouts in facilities. Initially, 63 that had reported they had contraceptive. So you can see half of them say it's yes, they have guidance, and then 47 no, and 5.3% said they don't know. So it's not really clear whether these facilities know how to manage the contraception. And then looking at what have on how or when these stockouts will be resolved. So when do they expect more? You can see it's quite varied. It's varied days to like more than a month. So there's no, again, it's not clear exactly. And then, so again, this should have been, this is just again saying that 53% of these facilities had reported a stockout. And then available at the health facilities in terms of contraception. So most of the facilities, like more than 95%, are providing a range of contraception. At least this is what they say is available. And again, if you look at the essential healthcare, you will see that, these options should be primary healthcare. But whether the actual stock is there for the service to be functional is another question. And again, from the patient surveys, so here we asked the patients what was the type of wanted to access at the facility, and after male condoms, the requested type of contraception, depot contraception. So it is the preferred choice as well. We asked able to access their preferred contraception. So 96% of patients said yes, and then there was about 4.4% who said no. Now, just to the previous question about the type of contraception that they wanted to access was a multiple choice question. You can go and request more different types of contraception. It's not like you were asked about one, asked to tick all that apply. Everybody wanted condoms and the injection, but they were not able to get the depot injection, but they could have said yes, that they did get the contraception they requested. And this was a small sample compared to the 15,000 here, 316 patients applied to this question on the reasons for not getting contraception of choice. So this is if, you know, people were actually given an explanation as to why they didn't get. And more than 50% of these patients, again, said that they were told there's a shortage or a stock out, and then 25% told that they had to come back. 19% said that their first choice was not available. But all of these top three options, a shortage or stock out, if you think about it in terms of what the clinics, and that will stop there.
Thank you so much, Indira, for those insightful statistics. I think what really is highlighting contraception is a very big problem. You know, the fact that you'd have 40% of, you know, not getting access to contraceptive in comparison to other medicine. I think in other diseases, I think that's very problematic and something that needs to be addressed with urgency. And I think also for my side, just looking at, you know, despite having an alternatives, and some of, you know, women who were seeking these contraceptives were given alternatives, I think the fact that women are subjected to using contraceptives that might not be suitable for their own bodies, I think that's also just taking away from the ability to choose, and just from their right as well to have preferred methods of contraception. So I think that's very important. And yeah, moving on to our next speaker is Usihle Shabalala, who is a nurse by profession, but her activism drew her to the work of the Treatment Action Campaign, where she works as a provincial manager in Mpumalanga. She has contributed to the development of sexual and reproductive health rights clubs in the province. Her vision is to see SRH being prioritized because it gives women the option to make autonomous decisions about their own bodies and sexuality. So the most interesting bit about this report is the use of patient experiences as an alternative perspective to routine health information. So Sihle will take us through the health user impact as well as how women on the ground are affected by these stockouts. Thank you. Please take the floor.
Thank you, Candice. Hi, everyone. Candice, we know that as women, we use contraceptives not only to prevent unplanned pregnancies, but also to improve our health. And not getting what you prefer or the contraceptive that you prefer, obviously you would have to go with, it's either with the available contraceptives, or you will go home empty-handed. And this has affected or impacted women badly on the ground, because the switching and stopping, if you decide not to take whatever is available at the time, it's not good for our health. And also, those that use contraceptives to prevent unplanned pregnancies, they may get pregnant. And with that, it goes with your confidence. you lose self-esteem, and it goes with your emotional, physical, and also financial. It affects. And also, lastly, your relationship, because these things are discussed. You don't just wake up and get pregnant. You discuss it. And also, given an option, having variety of contraceptives, it makes life easier, and it improves our self-confidence as women. But experiencing stockout, it has affected a lot of women. Others have decided to stop at all. Others have decided to go with the other alternative contraceptives, which were not good for them, because we know that side effects affect us a lot. We have different side effects. Hence, we decide to have our preferred contraceptives.
No, thank you. I think that's very important insights. I think just also touching on the agency and the ability to choose. And I think you raised very important points around, around contraception and how it actually has impact on other, besides you preventing pregnancy and having that autonomy to decide when you will have kids. But it also is very important to boost your self-esteem, to improve your health overall, but also, to enable you to even participate in other, forms, either in the economy. I think it's very important, and we just might look at it as just a way of like preventing pregnancies and stuff, but it actually taps into other aspects that are not necessarily given attention. And I think the fact that women get to stop, and I know personally women who have had to stop using contraceptives because of stockouts, also because some contraceptions don't treat you well, and that in itself contributes to your own self-esteem, and I think that's very important, to highlight some of the effects. And I think it's a very topical issue when I meet with other women. Topical issues that how does this treat you? This does not treat me well. And unfortunately, there was a time where this issue has been even more prevalent. We were subjected to using contraceptives that are not suitable for our bodies. So I think that's an injustice to women. That's an injustice to us even participating in the economy in general. So I think moving on to our next speaker, who is online, Lucy. She is a sexual and reproductive health nurse and currently works as a key populations advisor working for Doctors Without Borders. With over 20 years of experience, she has a particular interest in promoting comprehensive, accessible services for key populations, adolescent and young women, through engagement and empowerment of peers within healthcare delivery. Lucy will give us a perspective on the health system impact. Please go right ahead, Lucy.
Thank you. Can you hear me?
Yes.
Yeah. Well, thank you for this alarming report and inviting me to the panel. I work with Doctors Without Borders, MSF, and I have been based in South Africa for more than 10 years. So, this report shines a light to the many health system issues affecting contraceptive supplies and shortages. As a nurse myself, I can sense and speak about the absence of support to the frontline healthcare worker who are more than aware of the contraceptive needs of their communities, yet have limited agency to demand adequate supplies and services. The health system is under-resourced and understaffed. I can see it. Nurses and other frontline healthcare workers are often overloaded, working without supervision or support at the ground level. This includes lack of capacity building and training on the provision of new other methods of contraception, like the longer lasting reversible modern methods, such as implants and intrauterine devices. So not knowing how to provide a method also plays a part in stock orders. Low demand from the client can also be a result for the low promotion or the request of these methods. So also, as healthcare providers, being updated on latest guidelines which ensure safety and efficacy of the different methods of contraception, expanding into the demedicalization of self-managed methods, such as the self-injectable and vaginal ring methods, would begin to ensure that women have an assured autonomy of their bodies regarding contraception. So women are increasingly in need to rely less on clinics to get continuous access to contraceptives, especially when stigma and discrimination is a real barrier to accessing healthcare for people such as sex workers or people who use drugs or the too young to be on contraceptives. So task shifting service provision with peer cadres can be actually life-saving. So often we may not as female clients to be able to self-manage our own choices, and the demedical services may pose challenges to conservative medical approaches. Women taking contraception have made a choice, have made a decision not to get pregnant. When supplies are broken, we take away their agency. It's to have to change from a long-acting to a daily method or just condoms. Those seeking contraception give up days of work, job security, childcare, and it's hugely costly to our post-COVID economic. It can be more costly and time-consuming to the woman to ensure continuous contraception. So we especially let down the most vulnerable, such as the young and adolescent women, those with children and babies, those who migrate for livelihoods. We need the confidence of sustained access to contraception to stay in control of their lives. So we often have TB and ART, post-exposure prophylaxis, pre-exposure prophylaxis to HIV treatment to match with contraceptive options and access, as well as other consultations following, for example, sexual and gender-based violence or safe abortion care, or CTOP, as it's called in South Africa. These are golden opportunities to enhance integration of care. But with contraceptive supply gaps, we increase the risk of unplanned pregnancies for these vulnerable patients as well. So this report does not dig into the stockout of medication abortion pills, for example. It is my hope that as we continue to unravel the challenges and barriers to access to sexual and reproductive health care in South Africa, we eventually take a close look into this. And we have had a long-standing problem in a country where abortion is legal, and mifepristone supply in this country is super inadequate. Not just the supply, but the training and willingness to offer the services. So it is concerning when the lowest common denominator contraceptive option of the decades-old injectable is out of stock. It indicates lack of stewardship from the part of the NDOA, with limited investment in reproductive health commodities, supplies, and reliance on the market of other NGOs. This leaves those seeking access to reproductive health and bodily autonomy. So after this became constitutional right, and it's a visceral blow not celebrate Women's Month like this.
Thank you, Lucy. I think you touch on very important aspects, particularly on the absence of support to healthcare workers, and that and as much as we might have policies and the law encouraging access to contraception, but our health facilities are under-resourced, and therefore health workers are not able to assist or do they work efficiently, but also in some cases lacking some kind of understanding on some or lacking some information and knowledge on providing other means of contraception. And I think also just touching on even our health facilities discouraging young women. I think for me, it actually just points to us even having more tailored solutions to address and to basically encourage young women to access these facilities. Because in as much as, I think we have seen statistics in South Africa where young women, in high school and primary school getting pregnant, and I think that is a glaring issue. It's a very huge problem in South Africa. What are we doing? I think issues around contraception is a huge one, and we need to educate our young people, but also tailor-make our systems to ensure that it actually encourages young people, school-going kids, to get access to contraception. So thank you so much for those words, Lucy. So moving on to our last speaker, before we dive into a question and answer session, I'd like to give the opportunity to Ubaone Twala, who has a heart for more vulnerable members of society. Consequently, her interests revolve around systems, how they work, and how they can be improved through law and policy. Baone has an extensive background and an understanding on human rights, public interest law, and policy issues. She previously worked at the Center for Applied Legal Studies, the Constitutional Court of South Africa, and the Supreme Court of Kenya. She's currently part of the health rights team at Section 27, where she works as a researcher focusing on access to medicine, HIV, and the law, and the right to food. Baone will be taking us through the legal frameworks on how does a lack of access to contraceptives compromise on women's rights and their right to access to quality health care in South Africa.
Okay. Thanks, Candice. I think that I'll be brief and I'll touch on 3 points. So I'll discuss what the law and policy says, and then I'll discuss the meaning or the impact of the violation, and then I'll discuss the knock-on effects. So it's undisputed that the law provides for people's right to access reproductive health care. In fact, the Constitution expressly provides for access to reproductive health. Consequently, it also provides, it places a duty on government to fulfill this right. And in this particular situation, the gaps are in the implementation and not in the law. We even see in policy quite a strong recognition for providing for how people can access reproductive health care, from contraception to abortion. In 2019, the National Department of Health released the National Sexual Reproductive Health policy, which provides for the things that we're discussing today, that women should be able to access the contraception of their choice, that women should be able to access long-acting contraception, whether that's the injectable or whether that's intrauterine devices. And so when we look at the theory and when we look at the law and the policies, these things are already provided for. But there seems to be some kind of broken telephone between what's provided for in the law and policy and then what we see on the ground. And so somewhere along the line, something's broken in the system. And so there's a provision for these, for this right to access reproductive health care. But then when a woman shows up at a primary healthcare facility or a clinic, the contraception isn't there, or they don't have the choice. And I think that it's also important in this discussion to be aware not only of access, well, of the meaning of access to reproductive health care, which includes the ability to choose your preferred contraception. So what we're finding then is that even though we have these laws and policies that provide for these reproductive healthcare rights, if a woman shows up to a primary healthcare facility and that contraception is not there, then that means that government has failed in its obligation to provide reproductive healthcare to women and to girls. And the failure to provide reproductive healthcare is not just limited to that right, but it violates, as Candice had mentioned earlier, so many other rights, you know, such as dignity, freedom and security of the person, you know. And so when you think about freedom and security of the person, maybe it sounds a bit woo-woo, but really it's the ability to be able to choose when you want to have children, to be able to decide how you want to proceed if you're unable to continue with the pregnancy. And regardless of personal opinions or moral standpoints, people have a right to access those services, and government has an obligation to provide those services. And so when we're talking about reproductive rights, we're not just talking about, oh, but you can use a condom, because we also have to consider the socioeconomic conditions in South Africa. So for example, as a woman, if I can't access a preferred contraception choice, which, for example, say, the pill, and I control that, I take it when I please, I don't need anyone's permission, but, there are disparities, in power relationships between men and women, and if you, for example, go to a clinic and you can only access a condom, there are so many more steps to being able to control your own body, in that you now have to convince someone else to use a condom. And so it's very important to understand that the right to reproductive health care is not just about, or at least you have something, but that it should be something that works for the individual, not only physically or in terms of our health as mentioned, but also just that it's your choice and you have a right to that choice. And so the failure to fulfill this obligation is also a failure that violates so many other rights. And then this issue about access to contraceptives is very much one that affects women and girls who are more vulnerable members of our communities. And so, for example, like I said, there's so many other rights that are affected, and because of the state and the place that and the position that women hold in our society, it also affects, their right to equality and their right to be able to make decisions. And when we then look at the access to reproductive health care holistically, and we see, things like a lot of people seeking out illegal abortions, or a lot of unplanned pregnancies, and people could complain about the burden on society of so many children by people who are most likely the people that rely on the public healthcare system to provide contraceptives. We then see that the chain of that problem begins way before we see those consequences. So a failure to provide contraceptives forces women to then have to come and re-engage with a system that failed them in providing contraception, to then come and ask that same, to seek abortion from that same system, and then have that system fail them once again, and then become dependent again on government to be able to support them financially. But obviously there are many other implications to unplanned children, but also many other implications to having to seek out illegal abortion, because government once again does not provide those services as they should. So when we see those kinds of things, when we see government leaders marching against abortion, we should be thinking about the chain of the chain of where this thing starts to break down, and that holistically our government is failing to fulfill its obligation to provide people with their right to access reproductive health. Thanks.
Thank you. Thank you so much, Baone. Thank you so much for that. I think it's very important things that you've highlighted. I think firstly on the power dynamics in relationships, and I think it's something that we all know that in most of the cases women have to convince their partners to take contraception, and also just I think bearing the economic costs that come with it. And sometimes you need to go to the clinic, and you need to take a taxi to get that. It all falls on the women. Men don't even have to think about that. So there's a lot of things that actually that come with actually even taking the contraception. And I think it's very important to highlight those things and having to go to a clinic where, you know, there is, and as highlighted in the report, that some have had to turn back and return back to come another time. That is in itself in an economic burden on women to have to use to get transport money to get to the clinic. I think also just highlighting the disconnection on the law and policies, that we do have the laws, we do have the policies, and they're provided for. However, there is a disconnect on the ground. And yeah, I think also just talking around abortion, safe abortion care, which is a very important topic also that would require another, discussion altogether. And I think it all starts even on the lack of contraception, a lack of access to contraception. So thank you so much for those thoughts. And yeah, I would like to firstly just give a warm round of applause to all our panelists before we go into so I think now we are going to go into a round of question and answer session, and I'll kick us off, seeing that I'm the moderator. So I will just firstly I think just going back to Baone, I think it's very important for us to also I think this report has highlighted what we see in clinics, but I think what is of interest to me is if whether this is happening, is it unique to South Africa? Is it a global problem? And I think it's something that we have seen also when it comes to vaccine access, for example, that in as much as we wanted to get access to vaccine, but there were so many powers or global powers that was enabling access to vaccine and the inequities that we saw with access to vaccine. Could you say that similar challenges are there for contraception and accessing contraception, not just in South Africa, but at a more global level?
Okay, thanks, Candice. Okay. I think in terms of does this happen anywhere else? It's a problem that seems to be prevalent in middle to low income countries. I understand the issue superficially, but my understanding is that it's basically a supply chain problem, and so there have been recommendations about how those logistical issues could be improved to ensure consistency in supply of contraception. But I think if we consider the South African situation, contraceptive stockouts have been an issue. As Stop Stockouts, we started hearing about this issue already in 2017. We were trying to engage government in advocacy on this issue, and so it's been ongoing for a long time. I think, if anything, as with everything else, COVID exacerbated the situation, but it's not necessarily something that we could say is new. And I think that government really needs to step up its game in order to find out, where the issue is and to resolve it. Thanks.
Yeah, sure. I think that's very important. I think it is very important to also look at a global lens to this, that in as much as holding our governments accountable, and I think also just for my line of work, it's very important to look at the pharmaceuticals, things around access. And I know with mifepristone, which is an termination of pregnancy pill, there has been some supply issues on that. And one of the identified issues around that is because there's only one supplier, and also that actually obviously exacerbates the price in which it costs to actually buy that, So on top of, all the issues that we are facing with challenges on the ground, whether people don't want to provide, termination of pregnancy services, there are other issues around, supplying and the cost of it, and whether governments can afford to even purchase that. So I think it's, very important to also, and I hope it's something that going forward, even with the report, a lens that can be taken and looked into what are some of the global issues or perspectives when it comes to manufacturing, when it comes to production of contraceptives that actually affect our ability to supply this. So moving on to Sihle, I think as mentioned that this was a community-led systematic collection of data which centers patient experiences of health impact. What would you say is the importance of using such methods for future data collection and health impact solutions?
I think because when a person share their experiences, nobody can deny that, and it's important that we understand personal testimonials are very important. You can never go wrong with it. Yes.
Yeah, and I think that's very important. I think centering people, I think it's not just numbers, but centering people's experiences is a very powerful way of conveying messages. And yeah, I think it's quite an innovative and actually very interesting way of how the report was compiled, and yeah, just getting that this is actually women who are directly affected by this, and this is what we are receiving. So thank you for that. Moving to our online panelists, I think going to Indira rather, what could be some of the reasons to these stockouts in South Africa? I think we have level in manufacturing, but what would you say are some of other reasons we are encountering these stockouts?
Yeah, thanks, Candice. So I think that there could be a range of reasons. And supply chain, it starts the procurement of the medicines down to the actual delivery into the hands of patients. And so, it's a supply chain with many links, and there could be numerous interruptions point there. So, all we know is that these patients are saying they're not getting it, and we've, health facility staff have been out of stock, and they don't really know response about how they can manage it or when they can expect more stock. So unclear at this point to say what exactly is the cause, and we found some information. There was a disruption in or an end to the contract that Health had with suppliers, and then we didn't really find any more information. The idea that, well, there are other options and you should just, offer something else, really not sufficient actually, and it could be harmful, as Baone has explained. It's harmful in some cases. So we really just can the situation be resolved? Like, that's the message. Thanks.
Thank you so much, Indira. Moving on to Lucy. So you work in affected communities and interact with various stakeholders on different levels. And I don't know if you maybe can reflect on a particular stockout, maybe on Depo-Provera, which has been mentioned as a preferred choice for most people, that there were actually stockouts on that, and how this affected communities, but also maybe reflect on the kind of interactions you've had with various stakeholders. Do you get a sense of these issues being prioritized by officials, for instance? What's the level of their prioritization of this issue?
Hey, okay. So, yeah, I mean, Depo-Provera, not having Depo-Provera shows a neglect, gross neglect, outrageous around women's health, because it's kind of, one of the easiest, simplest methods of contraception that you can provide. For me, when I was listening to Baon as well, and the rest of the speakers, is what stays in the silence is, who is funding contraception today? Who is holding the budget? How can we find accountability with this situation? So within the national health system, because of course, as external agents like MSF, if we find stockouts and we have a particular, target group that we're working with, particularly, I don't know, if we're doing adolescent health, or we're doing sex worker programming, or we're doing sexual violence programming, we definitely don't want to have people go without their preferred choice of contraception. So we tend to sort of gap fill. But then we find that when we manage to do that, and we start pulling out, or we say, well, this project is done, we see that the national health system doesn't find a way to continue the normal bog standard array of methods of contraception that women should have access to according to their policies. So for us, I think as externals, international NGO, we tend to come into this sort of silent barrier of not really knowing who is in control of the budget for sexual and reproductive health commodities, and because is it outsourced? Who do you outsource it to? Who has the tender? All that sort of thing. So the complication there is I don't want to say it, but it's somebody has it, and there has to be some kind of way of getting the accountability more visible, transparency into the mechanisms of managing these health systems. So the policies, as Bowen was saying, the policies of 2014 and 2019 were both talking about increasing method mix, but we still have stockouts of 60% of injectables, and increasing the quality of care, which is actually all about human resources, accountability, and governance. And that includes, all the bodies, the medical bodies, the nursing bodies, to be participant in this drive. Smooth and access to contraceptive care to women in South Africa. The word that I don't want to say is there's somebody not sitting on budget for something else. Somebody's getting low, and we don't have a way through to knowing how to break that cycle.
Thank you, Lucy. And I think, very important that we get some level of visibility on, how we hold the government accountable. At the moment, if we encounter these stockouts in clinics, who do we go to? If Stop Stockouts is not there, who do we go to? I think that's not very visible, and definitely there is a need for more visibility on that. So I think I'm going to turn to the audience, and if there are any questions before going online, a couple of questions from the online audience, but just to, I think for those who are with me in the room, can we just there's already a hand that side. So anyone with a roaming mic, please just.
Thank you so much. This is Fiso Nkali. Actually, whenever we talk about the subject of drug shortages in facilities, with me in mind, there comes something like food security, just sits, I'm not sure if it sits well with you. Why am I saying this? It's because I do understand that whenever we buy drugs, medication, we need to have something in reserves. And that can be able to last for at least 4 months in case there are emergencies. And for instance, as what happened last year, is it this year, during the floods in KZN and all that. If there are wars and stuff like that, we know that we are safe in case anything happens with the depot, or either the manufacturer and all that stuff. Don't we have such with the Department of Health? And because I thought like maybe it should be minimum of 3 months, up to 6 months, that stock that should be able to last for such long, that we can just run dry with all facilities without having such reserves, So that makes me feel so frustrated at times when I think the drug shortages that we don't we have at least reserves in case anything happens that is not expected? We didn't, So that is my frustration right now. Thanks.
Thank you, and I think it's a very valid frustration. I think there definitely is a lack of being prepared from our government, and I think we also saw, which is a very topical issue. I think even now going into, we have seen with COVID and a lack of, how do we best prepare ourselves for emergencies? And I think it's something that we need to consider, even for our local issues. That how do we have like a plan in place to mitigate when we have such problems. Sorry, I see someone at the back. Yes, please.
Good morning, if it's still morning. I go by the name Sister Fix. I'm actually a primary healthcare clinician. I'm a nurse specialist by profession. And I'm also a nurse activist, something that you don't see. Because I've always felt that with all the activists that are there, actually we are being left out. And unfortunately, we have more to say, whether we get whatever that comes afterwards. But here's my take on the issue of contraceptives and stockouts. I believe that clearly that is access denied. We are not even going to have to look left or right at the end of the day. While there is stockouts, that is access denied. Worst part to women. One of the interruptions, yes, it has been noted for the past, I think it has been the past 5 years, whereby there's been a slope down in terms of acquisition of family planning. That has been happening in the public healthcare sector, especially in Gauteng, whereby issues like when you want to look at the termination of pregnancy, remember it was under a grant I get from the USAID or PEPFAR, and there was that change of that actually took us, it gave us a knock. Why am I saying that it gave us a knock? It is because when our system again becomes dependent and actually cannot itself be able to take the pressure that it is in, then you find a situation where a department does not even train nurses for TOP. You get a health department that is standing with an education wing, if you want to say, but they are not training nurses on the termination of pregnancy. Now there's been a run-up of trying to get as much nurses and trying to get as much facilities to be doing termination of pregnancy as if it is an alien service. That is something that we need to also, when we speak, we also need to say, when we speak of women issues, why must they be sacrosanct? As if we need to be having such areas to actually even discuss what is happening when it comes to women contraceptives. Yes. There's been a slope, a downfall of acquisition. We do know that. And it would be quite nice to see between the cohort that is being said here, between April and June, what has been actually the TOP coverage during this period. Because that would actually give us a light to say, did this cohort time of period actually put a dent in a woman's life? And hence I'm saying even the TOP services, it would be quite interesting to see the demand versus the TOP's services that are going there. The stock saturation, I do concur with you. When you are in health, it's like you are working with people who are not health inclined. And there is logistics. There are people who went to logistics, who studied logistics. There are people with MBAs, but people don't see a tender when it is about to finish. A whole department. I would also say even us as activists, do we know the tenders that are out there? Are we actually perusing what is actually being given to our clients? Are we actually dealing with the real problems that are there and that us, even as health workers, face? I will go to the tender issue, but I'm not going there. I'm on the contraceptives. We are failing in adherence because of the 20,000 companies that are doing ARVs. When I have to adhere 11 years, today I have to tell them about Tribus. Tomorrow I have to tell them about Atroiza. The next day that formulary is not available. There is now Mduduzi. Mduduzi now is no longer doing it at the strength that the other companies have been doing it. I have to now re-educate and re-challenge this child to say you were on 200. But because the department has decided to sign with Juta is only doing 50. You need to take 54 of those. Hey guys, there is real trouble in our community health centers. And we need to get down as activists to the problems that are there. I'm quite shocked. Nobody is saying anything. One thing that made me come here, because I'm going to Hillbrow, there are no condoms. There are no male condoms, guys. And then what is the alternative? Because you know, even lessons, well, they are lazy. We know, Shem, maybe they are lazy. The people are too much. Sometimes you're just tied to saying ayiko. You ask this one, ayiko, ayiko. And then definitely by the 10th person, you will be, hey, ayiko. That is what we are selling in our facilities. There are no condoms. Now we are at this cohort of this era. There were no condoms. There was no contraceptives here. There were no condoms in our facilities. What have we done to these women? A tender apparently was ending also in some, and yes, they want to put your DOMs and your other types of condoms into the system. But then why are we making the whole system go down? While we're looking for alternatives this side, why did we lose track? Because we do know that not having a condom, that is the number one preventative for HIV and other sort of illnesses that are out there, very monkeypox. And those are the issues that we have. We do not have condoms in our facilities. And no, it's not in the media. Nobody is saying anything. And tomorrow, when all this influx of women who actually have found themselves out of the way, they don't even have to explain themselves. If I want to drink Coke, I want to drink Coke. If I want to use Sprite, I want to use Sprite. But when it comes to women, we have to tailor-make things and make them demand, make them match. Who is being taken to task, to court for no condoms in Gauteng currently? Can we have people being charged? We are having people sitting in offices there, sitting with files, having laptops, but nobody saw that the condom tender is going out. Your strawberry and your what, they know, is because we want vanilla. While you are still developing vanilla, continue with that banana and strawberry that we've always been having in the facility. Hence, I say also, even yes, like I'm saying, I would love to see the programs like the retreaters. We welcome, I'm part also of the ops manager team. They do come and do the facility monitoring of management. You know, they do come and come in the next quarter. And come in the next quarter. And you know, it's so funny because our healthcare workers actually think that change will come. Can we be loud enough about the findings that we find and not compromise the very healthcare workers who are going to take a beating when they cannot even have the capacity to do TOPs of more than 10 in a facility? And the dates apparently of pregnancy, we don't have the luxury of time. We don't have a luxury of time, and that's one thing we need to understand when we're dealing with women issues. We do not have the luxury of time. Let us plan. Let there be systems. Whether there is a change of leadership, there is a change of political climate, there is a change of whatever climate, what are the systems that we can say as activists we are part of? And we make sure that they hold. When everything changes up there and down there, how an appendicitis is done, it will remain how an appendicitis is done, even when it's done by a different surgeon. Can we get those systems going, especially for ARTs? There is a lot of a mess happening in our facilities. Tenders are a problem. Tenders, there is this badge when you would have given it, because even activists are not going to these companies. You will find that women will come back pregnant, but they were ordinary straight. And it will be, it's you, sister, you didn't do the procedure, gosh, and all those things. But when you look at the timing and you look at whatever that is happening, somebody needs to account. People are just giving public consumers whatever that the tender they can acquire. They control how we give medication. They control our adherence scope. They change even the side effects, and they make it difficult for patients even to adhere to some of these some of these treatments that we are giving. There'll be this green panado, it's okay. Then there'll be this the drugs, ART drugs that are done by these other companies. Their gel will not sit well with the clients. Where do we voice out those challenges as healthcare professionals? Thank you.
So much. That's yeah, very, very powerful thoughts, and thank you so much for those reflections. And yeah, I think you've also just made a call to action that we should be even more louder about our findings and what we get here, and not just sit on it and that it ends here. Sorry, I have another question, and then I'm also going to go to the online people.
No, thanks. I'm Solanga Solimlambo. I'm working for Section 27, based in Limpopo. We are running the program of SRHR and sexual violence, where we train community members, more especially with learners at primary and secondary level. And the challenges that we encounter, of which these learners are raising, is to be turned away from the clinic when they have to go and access for contraceptives. It is worse if one is pregnant, if she wants to access the safe abortion. That's why at the end, they see an option to go and do unsafe abortion, which caused lives and consequences if one will manage to survive. So I think we also need to come with solutions or possible solutions on what do we think need to be done in addressing those issues, because services are there. There is no shortages in terms of the contraceptives are there. Nurses are also there. But these young girls or this girl is not accessing what is meant for her because she was turned away. 2, what are we saying or what do we do with nurses that have been trained to conduct safe abortion, but because of their religion, she will say, my religion does not allow me. And the government is not doing anything. So what is it that we think need to be done or to be strengthened so that they can able to perform what they've been employed to do? Number 3, I think she has touched it, because some of the shortages in terms of the contraceptives, even ARVs, are caused by the tenders. What needs to be done in holding government accountable and also even individuals? When it comes to the change of contracts of these tenders, they are aware that so long as tender is coming to an end in January 2023. But come January 2023, there is no new contract that have been signed. We're gonna take more than 3 months, 6 months. They are still battling with court and whatsoever because Solanga doesn't want to move out. While women, young girls, and young women are in need of these contraceptives and these other treatment or services that they need in terms of the SRHR coverage. What is it that we need to do? Because the department, they are aware, but they will wait until January come to an end, but there is nothing that they are doing. When you check, they will say, no, this is nationally, or maybe this is provincially. But they knew they have signed 5-year contract. So I think we need to see what is it that we need to do in holding government accountable and these individuals, because they are individuals that are supposed to making sure that they oversee and make sure there is a review before the contracts come to an end, of which is causing a serious shortages of condoms and other contraceptives? So those are my questions, and it needs all of us to see what is it that we need to do in a change of what is happening in our country. Thank you.
Thank you. Thank you so much. So I'm going to turn to my panelists just based off the reflections that have been shared and some of the questions that have also been asked. Can I ask each of you to just share some short, very brief reflections, and then I'm going to go to the online questions. Lucy or Indira first? Lucy, maybe you can go.
Well, I mean, for me, thank you so much for the reflections of on the floor there. I mean, to me, it does speak out loudly about the absence or the kind of lack of accountability of the Department of Health top officials being around in this kind of meeting as well, because these, now we get stuck because all of us who are here, I think, know the trouble. It's just that we do need to find the line to unlocking that silent issue of, who is holding the budget and where's that money gone and all that sort of stuff. So for me, I mean, when I hear about, contraceptive stockouts, obviously, do relate directly to issues regarding safe abortion care and how we really need to be even more than responsive to this, because definitely there's going to be more unplanned pregnancies when we miss the continuity of our being covered for preventing unplanned pregnancies. And similarly, with the complication of the different types of drugs that you were talking about, I don't know if it's ART or TB drugs or any other type of medication that puts, it's unacceptable for our patients. So the whole system seems to be at a bit of a kind of disarray, or there's a sense of lack of rhythm, that actually women do need. We do need a rhythmic reassurance of health services and medications to be there, present in the health facilities. So I think maybe Indira might have more reflections on this, but I think we're all on the same page, and we need to keep on talking about this. We need to probably find another forum. Thank you.
Thank you, Indira.
Thanks. Yeah. So specifics. I'm just really disappointed that there's no DOH personnel present these questions, because this is really now the ball is in their court to give us some answers. Maybe we'll get a media release after this, and we hope that it explanation as to when these problems can be resolved and maybe the reasons are. But at this point, we just want to know when it's going to be fixed, because as you've heard, it's obviously even today. And you heard from comrades in Limpopo from Section 27. It's really affecting young girls, and this is not the future that we should life that young rural women should be expecting in South Africa after more years of democracy. This is really just disappointing. Thanks.
Thank you. Sihle?
Now I can tell that we haven't done much. It's time as women we go out and mobilize other women to go to the street and paint the street colorful and demand what we deserve as women. And the health system needs to be fixed, and we are the only people who will fix it.
You have anything to
No, thanks, Candice. I think I was covered by Indira.
Okay. All right. So I just have a few comments actually from the online people who are joining us online. Think it's more of a question. I've tried to rephrase it a bit. I hope that it will cover what is being asked, mainly on the implications for school health programming. I think, yeah, so what kind of balance can we have where school health programs are against advocacy, for, advocacy around access to contraceptives either at school. What is it that we can do to actually reach young girls going to school, as mentioned, that sometimes it does become a problem to even for them to access these health facilities, either they turned back or, there are, various challenges that they encounter. What can we do to also create that, balance, especially in the just in the health school health programs?
I'm not very familiar with schools as access points for healthcare, but my understanding is part of the issue is that schools are not access points for healthcare. And so the issue seems to be that, you can't come and distribute contraceptives at school because learners are there to learn and not to get contraceptives. So that seems to be the disjuncture with schools as a solution for that issue. Maybe there are some colleagues from the floor who would be better placed to answer that question.
Yeah, I don't know if Lucy, I think maybe just reflecting also on some of our projects, other than them, do we have, sort of tailored projects that focus on attracting young girls to get access to contraceptions?
Yeah, I mean, so we have tried. I'm not sure if these nice programs that are started up are able to continue, but definitely linking the teachers or educators of schools with health facilities and training the educators in their schools about the availability of services around their areas, training, so a lot of that kind of work comes with comprehensive, reproductive health knowledge. But yes, as Putu was saying, I mean, we don't really provide schools are not health facilities, but definitely there can be a linkage to the mapped out health facilities. And so these are the kinds of things that we have done. We have also worked with peer driven sort of programming, so that a couple of the students of schools can be the contact points for these sort of services as well. But these rely on specific interventions. There isn't a system that I think it's as far as I know is working at the moment.
Okay, thank you. Thanks, Lucy. So we also have a question from Dr. Jess Russell. So he also wants to know if the research got any information, even anecdotal, on coercive delivery of contraception. So in his own research, he has found, sorry, another question is... So in his own research, he has found coercion where patients commonly receive the 3 months injection immediately following childbirth. So he's curious to know if a lack of one contraception has impacted delivery practice. I don't know if maybe Indira can answer this.
Thanks. So in the Richards data, this is not something that was asked, so we can't comment. And I think that there's a lot of other factors there that you'd have to ask about. Something that you could just easily explore with the clinic-based monitoring. It would probably require more time. So simply no, we did not ask about that. But then some of the reasons that people were given as to why they didn't receive the contraception they needed, some of them are quite worrying, which you can find in. And that this issue is really like across the board. It's across the 7 provinces that were surveyed or that are surveyed. So it's not linked to province. You can find also province-specific information at the end of the report in that. And also, it will be ongoing, as I understand. Richidze has kept these questions in the current quarter that they're doing. So if you go onto the dashboard, you will see what the progress is with some of these. If it improves after this, that would be great. Or if it stays the same, then again, what is the response from the DOH? They were invited to be here and to comment as well. Thanks.
Thank you. Thanks, Indira. I'm also quite conscious of time, but I think most questions that we receive from online had been covered as we were talking. And I also have a hand right at the back, and then there's another hand, and then I will have to wrap up. Yeah, so more hands coming up. So.
Good morning. I think, the report's very, very concerning, given that we have these stockouts across like all 7 of the provinces that got surveyed. But it also raises some concerns as we move forward. Coming out of the International AIDS Conference, there's a lot of talk around the provision of PrEP in these facilities. And one has to ask, if we can't deliver sexual and reproductive health comprehensively, what does that mean for the fight to HIV through the introduction of things like PrEP that targets young women that unfortunately disproportionately bear most of the new infections? And I think also when we're linking to broader universal health coverage, access to reproductive and maternal child health is an important pillar of that. So I think part of the conversation is not just about the provision of contraceptives, but also responsive services to young women. And I think we should use this report as sort of a capstone for a much stronger campaign around the strengthening of the responsiveness of primary health care at not just the provincial level, but even focusing on a district level to ensure that when we meet again next year to reflect on this, that we've seen some progress. But the lack of responsiveness from the system and the lack of representation from the National Department of Health at today's meeting doesn't augur well, and I think we need to push much, much harder for responsiveness to addressing these issues. Thank you.
Great, thank you. Thank you so much for those reflections. And yeah, I think very important points highlighted on strengthening our response on the primary healthcare level, but also just touching on PrEP. I think it's a very important issue, even on the access of it. The fact that it's not even registered in South Africa. First, for us to even access it, it's a bit far away because it's not even qualified by SAPRA for us to use it. I think that's a huge issue and gets to show, some of how we're also failing women, we're failing sex workers, we're failing, key populations in accessing, sexual reproductive health services. So yeah, thank you so much for highlighting that. I see, Bori's hand.
I work for Doctors Without Borders. I just wanted to try and understand what the Stop Stockouts Project will be doing in terms of demanding and accessing some level of accountability. So we heard previously that, for sure it would have been wonderful for the National Department of Health to be here, but I'm sure also, as Indira had indicated, there are some provinces that are more likely to have these stockouts from your report. They're pretty acute, they're quite prevalent. So what's the next step for the Stop Stockouts project in order to ensure that there is accountability? Clearly the health department was invited, they did not attend. Who did you contact, and what's your follow-up steps from here? Thanks.
Great. Thank you, Bori. That's a very important question, and I'll give it to our panelists. Actually, that's what I wanted to use as a question to wrap up our discussion. But I see another hand before we go to our panelists, and then we will, I'll get you guys to respond to that.
Good day. My name is Portia. I'm a nurse activist, and I was quite intrigued by the raise in school health nurse, as I was a former school health nurse, and it's a beautiful program, and unfortunately, it's been neglected by government. And the major problem in school health is the parents themselves. Remember, we are dealing with minors. Before we could even go to the schools themselves, the parents would say, no, we don't want our kids to be taught sex education. We don't want our kids to be taught about contraceptives and all other things. So it's even us as parents who are hindering these programs at the bottom line. So if we would advocate for school health, it's a beautiful program that in its initial phase was that it should also, each and every district is now linked to a clinic where you would have adolescents and healthy, friendly sisters that as school health nurses, we would refer to a certain clinic, and then they know that there's this nurse there who's not going to approach them as their mother, because if you are going there, there's a 60-year-old nurse, and then you are there at 13 in like contraceptives, and they're like, hey, are you starting to have sex? It's things that we should, as parents, also be consistent of. And I feel also tech and other organizations, you guys are operating in solo and not including us as nurses, because if at that time, when I was a school health nurse, I knew of such programs that tech is running there in the communities, it would have made life easier. But it's different organizations doing the same things in solo. And we are not coming together and solving the problem. So I think also we should work together, NGOs and government. I think that would actually give the solution to most of the problems. Thank you.
Great, thank you. Thank you so much for that. So I'm going to turn to our panelists just to also, in light of what Bori has asked, just to give your last comments, thoughts, and also I think it would be very useful for us to get to hear what the next step is. What are we doing following this report, the launch of this report? And I'll start with Indira.
So just to say that Richard's data being collected in clinics, at least the clinic-based monitors, it's done with knowledge and a cooperation. I would say it's a partnership even with the Department of Health. So they know about Richard's and available. When we compiled the specific information that we collected about contraceptives and we put it into our first, we did was share it with the DOH provincial departments as well as the national. Their input included in the report. We received some feedback, or at least some responses. It may be in the report. And we also to be here as well to take these questions, but unfortunately nobody has come. So we will be following up to hear if there's any response from any of the Department of Health. And then, as I said, we through the CHITSE if there are any changes to the situation, and to release a follow-up on what has gone on. But in terms of what the Stop Stockouts Project can do, you know, our capacity is just about bringing these issues to light and then trying to get answers and solutions. We are not involved in the actual service delivery. That is something that only the Department of Health has about. Thanks.
Moving on to Lucy.
Talking about healthcare workers, or particularly nurses, and I liked what person on the floor was talking about, the school nurses and their role. And I was just thinking, reflection, and a bit to what Bori was sort of asking, what to do next. I'm wondering, is there anything like a forum or a group of collegial nurses from all over the country that you can, are there any conferences, are there any meetings, annual meetings, or I don't know, 6 monthly meetings where this topic can come up, and there can be like a coalition of healthcare providers to improve access to, in this case, contraceptives, but or SRH, services. I don't know. Does that exist? I'm asking. Because, I mean, I am part of a coalition here in South Africa called the SJC, where we do connect with, the side, but I'm wondering that more specifically about the nurses and healthcare providers from the district health facilities, if there's such a willingness, or if that exists already, where we could probably do this talk again, with providers themselves. So it's a question back to the room.
Great, thank you. And yeah, if anyone has a response to Lucy's questions, please feel free to reach out to us. And I see Sister Faith's hand, but I will just put you on hold for now and then finish up with our panelists. Sihle?
So our strength as TAC is social mobilization. We can conduct community accountability meeting where we mobilize young women and girls in the present of duty barriers, where they share their experiences and also their demand, and then we monitor the demands with timelines.
Thanks, Candice. I echo what Indira said, but also just to explain a bit how Stop Stockouts works. So what we do is we monitor stockouts of medicines across facilities in the country. And this report is more like a big what's it called? Monitoring of a specific drug. But what people can also do is report stockouts to Stop Stockouts, and then what we do is we add that information to sort of like case management, because sometimes what happens is that the facilities themselves are not aware. There's miscommunication between the facilities and whoever it is that provides those drugs, and so Stop Stockouts up information and make sure that it reaches whoever it needs to reach for those stockouts to be resolved. And we will continue doing that, as well as continue to monitor contraceptives and see how those things change, in addition to everything that Indira has said. I also think that, part of the reason that we had this launch today was because we wanted to share this data with our partners and with the public, and we hope that they will also, take up that mantle and use this data to hold government accountable, to incorporate it into their various advocacy policies, and to kind of highlight where the gaps are. And all of us in our different organizations and the ways in which we work, we can think of ways in which we can alleviate this issue. Thank you.
Great, thank you so much. I think we are gonna close. Sorry, I'm just conscious of time, and I know some people will have to leave. But yeah, just to firstly, please give another warm round of applause to our panelists. Just thank you so much. Yeah, just thank you so much for being here with us today, and also just sharing your insights. I think it's been been a wealth of knowledge, and I really am quite hopeful that we will take this on to the next step and really do some practical practical next steps. And I think also Sihle has shared some very practical next steps in terms of what could be done in our respective organizations. So I think in closing, I'd like to firstly give a big congratulations to the Stop Stockouts team for launching this very important work. I think it will inform much of, and hopefully it will inform much of the work and decisions made by our governments, and will have pushed, have them to have a bit of more urgency in the work that they do, and to advance sexual reproductive health care for women and girls. I'd like to give a big thank you to the whole Richie Z team for all the data that has been collected, to the Stop Stockouts Steering Committee, Russell, Buto, who's in the room with us, Kopano, Sasha, Claire, Baone, as well as Indira. Yeah, big thank you for all the work that you have put in these past months. Also a big thank you to Lucy and Sihle for joining us in the panel today. Yeah, I think also just Section 27 for hosting us today. I think it's very welcoming, and thank you so much. And for all those who have joined us here, face to face as well as online, a big thank you to all of you, and just for being so engaging and participating. I think it's very very encouraging to hear your thoughts from the audience. It's been very important. So thank you so much. And just in closing, we do have some refreshments for all those who are here with us. Unfortunately, for those who are joining online, we will have some nibbles at the back. I'm not sure, Sasha, where people can go for some refreshment.
I'm afraid it's still on its way. The food should arrive shortly, so it gives everyone an opportunity to chat a bit more.
Yes.
And then we'll let you know where you can grab lunch.
Yes, so so if you guys can be patient, please don't leave Section 27 without eating. So if you have any questions to our panelists, or you have any questions to Sasha, Buto, they're all here, please do feel free to reach out. Thank you so much.